Hi, this is Peggy O'Connor again, and this is part 6 of the pre-class assignment, and this will be covering otitis media. This is a picture that's from your textbook, and it's showing you the tympanic membrane and how it should look. So one is showing you all the different parts of it, and the other is showing a tympanic membrane that looks normal. The etiology of otitis media is unknown. However, it is related to eustachian tube dysfunction because the eustachian tube links the middle ear to the throat, and that helps equalize pressure. So an upper respiratory infection often precedes acute otitis media. Pathophysiologically, allergic rhinitis, edematous eustachian tubes, blocked airflow, or air trapped in the middle ear tends to be reabsorbed and is replaced by fluid from the lining of the middle ear, and that becomes a perfect medium for growth of pathogens. There are 3 forms of otitis media. The first is acute otitis media, and that is commonly caused by viral pathogens, which resolve spontaneously, or bacterial pathogens, which do require antibiotics. The second form is otitis media with effusion, and many times this will occur after an infection resolves, where fluid remains in the middle ear, and that can occur over a period of several months. It can also occur because of the position of the eustachian tube, and it can also occur in a high number of cases in infants and children because of upper respiratory infections. The most common complications of acute otitis media are hearing loss, an expressive speech delay, tympanosclerosis, where there's scarring on the tympanic membrane, but there's usually no effect on hearing, perforation of the tympanic membrane. That will occur with acute otitis media and with the resolution, or chronic otitis media. Chronic suppurative otitis media, where there's chronic drainage via perforation or tympanostomy tubes. Acute mastoiditis, where there's an infection of the mastoid process. Intracranial infections that would include bacterial meningitis and abscesses. Otitis media is diagnosed with an otoscope that has the pneumatic attachment. They use SGAR, which is a special gradient acoustic reflectometry, which measures the condition of the middle ear by introducing sound and measures the tympanic membrane. I've already talked about acute otitis media, but I want to stress that it's an acute onset and it's visualized as a marked redness of the membrane. Recurrent acute otitis media means that there's repeated bouts of acute otitis media, and that's defined as 3 times in 6 months or 4 times in 12 months. There's also a YouTube link on this slide that will show you what acute otitis media looks like through a otoscope. OME, or otitis media with effusion, I have also talked about previously, but I want to stress that there's a fluid accumulation and no inflammation. There's a YouTube link on this slide that shows a myringotomy and grommets or tympanostomy tubes placed. In Great Britain and Ireland, they call them grommets, but in the US, it's called tympanostomy tubes. The third type of otitis media that I have not talked about yet is chronic otitis media. And what that means is that the otitis media continues for 3 months and there is a hearing loss. I have also placed a YouTube link that describes and shows chronic otitis media. Signs and symptoms of acute otitis media: fever, and determining if it's lower or higher than 39 degrees centigrade will determine what the treatment is. That's the definition of whether they have a fever or not. Complaining of ear pain or otalgia, fussiness or irritability, crying inconsolably, especially when they're lying down. They may be batting at or tugging at their ears. If they're an infant, rolling their head side to side. They will have poor feeding or a poor appetite. They may be lethargic. There will be night awakenings with crying or difficulty sleeping. There may be fluid draining from the ear, and there may be vomiting and or diarrhea. So the physical exam and diagnostic testing for acute otitis media is first that you're going to hear that there's a complaint of ear pain on the exam. The tympanic membrane may be dull or opaque and is bulging and or red. Sometimes there's green or yellow purulence that can be visible behind the eardrum. The pneumatic otoscope will show an immobile eardrum. If the eardrum is perforated, drainage will be present in the ear canal, and you can palpate for cervical lymphadenopathy, and tympanometry is not useful in diagnosis of acute otitis media. What I've developed here is a chart that shows treatment recommendations for acute otitis media. So based on the age and severity of the illness, the certainty of the diagnosis, it will tell you what the treatment should be. So if they're under 6 months of age and the diagnosis is certain or possible, antibiotics is the treatment of choice. If they're between 6 months and 2 years and you are certain of the diagnosis, antibiotics is the treatment of choice. If they are between 6 months to 2 years with severe illness, so they have the high fever as well as the symptoms, and it's possible that they could have the diagnosis, antibiotics are recommended. If they are between 6 months to 2 years with non-severe illness, the diagnosis is possible, then we do watchful waiting and observe them for up to 72 hours. If the child is over 2 years of age with severe illness, we are certain of the diagnosis, antibiotics is the treatment of choice. If they are older than 2 years with non-severe illness, but we are certain of the diagnosis, we will still observe them for up to 72 hours. And if they are older than 2 years and the diagnosis is possible, then we watch and wait for up to 72 hours. If we are going to treat with antibiotic therapy, amoxicillin is the first line of treatment. It's generally 80 to 90 milligrams per kilograms per day. And if we need a second line of treatment because amoxicillin doesn't seem to be working, we can use amoxicillin with clavulanate or cefuroxime. Azithromycin or Zithromax, cephalosporins such as cefnir, cefuroxime, and cefotaxime are also possibly used. Nursing management of a patient with acute otitis media requires the following. For a goal of managing pain, we want to use analgesics like acetaminophen and ibuprofen, and that will manage mild to moderate pain, and there's an added benefit by reducing fever. Narcotic analgesics may be indicated for severe pain. You can apply hot or cold compresses, have the child lie on the affected side with heat or cool compress in place. They can give numbing ear drops such as benzocaine or aralgan, and that may help reduce severe pain, but you'd want to use that with analgesics because there's a very short duration of the effectiveness. To educate the family, if the treatment is watchful waiting, we want to explain that rationale because that is a fairly new recommendation and it is now a best practice. We want to ensure that the family understands to return for reevaluation if there's no improvement or if the child progresses to severe illness. If the treatment is antibiotics, you want to explain the importance of completing the entire course of antibiotics. Many people stop administering antibiotics after 48 hours because the child has improved. We also want to explain the need to return for follow-up to ensure that the acute otitis media has resolved. Our goal of preventing acute otitis media is best implemented by encouraging infants to be breastfed for the first 6 to 12 months of life because they have a lower incidence of acute otitis media. We also want to avoid excess exposure to others with upper respiratory infection symptoms, avoid exposure to secondhand smoke, encourage parents to immunize the child with Prevnar and influenza vaccines, and it's also been noted for older children that chewing gum that contains xylitol, a sucrose substitute, can be protective. So older children can chew this gum. Younger children can be given xylitol syrup. For otitis media with effusion, Tylenol for pain, acetaminophen for pain, and antibiotics only if it lasts more than 3 months. For chronic otitis media, tympanostomy would be recommended and antibiotic eardrops, And if there's also nasal obstruction, an adenoidectomy may also need to be performed. This slide is talking about otitis media with effusion. It is a presence of fluid within the middle ear space without signs or symptoms of infection. It can occur independently of AOM or after an infectious process of AOM. The risk factors for OME include passive exposure to secondhand smoke, absence of breastfeeding, frequent viral upper respiratory infections, allergies, a young age, male gender, and adenoid hypertrophy. And on here is a picture from your textbook that shows a tympanic membrane that has OME. Surgical treatment of myringotomy and tympanostomy tubes and possibly adenoidectomy for recurrent OME. And then tympanostomy can be used to treat chronic otitis media and adenoidectomy if the chronic otitis media has a nasal obstruction. And this is a picture from your textbook that has it has the myringotomy and the tympanostomy tube in place. A nursing assessment for OME, getting a health history. Determine the extent of the symptoms. They may be asymptomatic. They may experience a popping sensation or fullness behind the eardrum, and explore for risk factors like passive smoke exposure, absence of breastfeeding, frequent URIs, allergies, recent history of AOM. For physical exam, the otoscope exam may reveal a dull, opaque tympanic membrane that may be white, gray, or bluish. If it's not opaque, a fluid level or air bubble may be visualized. Diagnostic testing is usually noticing the mobility of the tympanic membrane being absent or diminished with the pneumatic otoscope, and tympanometry can be done to confirm the diagnosis of OME. We want to educate the family in regards to the anatomical differences in children and about OME. We want to teach them that antihistamines, decongestants, antibiotics, and corticosteroids have not been proven to aid in the resolution of OME. It usually resolves spontaneously, and the child should be checked every 4 weeks. They should not be fed in the supine position, and you should not prop the bottle. We want to monitor children who've had OME for hearing loss, and when OME persists, that is the primary concern. Impaired hearing can cause significant language development problems. They are at risk for severe speech, language, and learning problems. For chronic OME, that is a persistent OME of 3 months or longer and should be referred to a specialist for hearing evaluation. If they are not at risk for speech concerns, they should be reassessed every 3 to 6 months. For nursing management, we want to have a goal of effective communication with a child who has OME and hearing loss. So turn off the music or TV to eliminate background noise. Position the child within 3 feet before speaking. Face-to-face speaking with the child. Use visual cues. Increase the volume of the speech slightly. Speak clearly, and request preferential classroom seating. Our last goal is postoperative care of a child with tympanostomy tubes. So standardized treatment is a surgical insertion of pressure equalizing tubes into the tympanic membrane. The tubes stay in place for at least several months and generally fall out on their own. It's usually an outpatient surgical procedure. So we want to teach the parents to administer eardrops postoperatively. They need to avoid water getting into the ear canal, so they either have to wear earplugs in the bathtub or while swimming, and there are special headbands available. PE tubes allow for adequate hearing and encourage speech development, but they do not prevent infection. If the child gets an infection, PE tubes do allow the infected fluid to drain. This is the end of the 6-part series, and now you need to go and on to Prep U and take the quiz, and then you will be ready for class. Thank you very much for your attention.